Hello everybody, we are on the final road to ICD-10. You all, I need you to take a breath, calm down, you got this. You've mastered ICD-9 and you will do the same with 10. We are doing the same concept of coding in ICD-10 that we did in ICD-9, so calm down. It's just that the codes are longer and more in depth, but you have this, so calm down. Some of the concerns that I've been hearing concerning ICD-10, transitioning of V57.89. We should still be using V57.89 until September 30th, 2015. That's the last day to use it. After October 1st of 2015, we're going to be using the real reason that the patient is in the nursing home as our 67. We're going to be doing the same mapping and coding concept. Can any other V codes be transitioned? Should we use therapy diagnosis as our main diagnosis? What will we do, because V57.89 is our admission diagnosis and it won't be transitioned over? How many diagnoses can I map? Now, these are some of the issues that we'll cover today. First thing, do not transition V57.89, everybody. We are going to be transitioning the real reason that the patient came into the nursing home or that they were admitted to the nursing home as our 67. If you map over V57.89, you're going to get a denial. This is not a valid code to use. The coding guidelines warns against that. We do not use those aftercare codes or those trauma codes as our main diagnoses anymore. Those V54 trauma codes as our main diagnoses anymore. We must adhere to the coding guidelines, and you all know the coding guidelines are in the front of your books. As right now, we still have those draft sets, but the coding guidelines are accurate. After October 1st, use the real reason for the resident's admission to the nursing home. You all know presently we use aftercare V codes when there's an injury, because we treat the resident in a subsequent phase of care. Let's say if we have a resident admitted for a healing traumatic fracture of the tibia shaft. Currently, we would code our V57.89 for the therapy, and we would code V54.16 for that fracture of the lower leg. Now, but when it comes down to ICD-10 and the residents come to the hospital to us, on their list from the hospital, they're going to have S82.251A for the initial encounter of the tibia fracture. Well, what we're going to do is we're going to code S82.251D for the subsequent, or what we know it to be as the aftercare phase of care. The 7th digit difference, you all. Now, you all remember when they come from the hospital, the way we will distinguish when we have those traumatic fractures or any type of trauma code coming from the hospital will append an A to it, and we will append a D to it. That's the only thing that now I told you always check behind the coders from the hospital. They're human too. But in normal cases, the only thing that we should have to do if it's coded correctly is change their A in the 7-digit character place to a D for the subsequent care. And here's the coding guidelines. The aftercare Z code should not be used for aftercare injuries anymore, you all. For aftercare of an injury, assign the acute injury code with the 7th-digit character of D for subsequent care. Now, also remember, we talked about this scenario too in our ICD-10 training class. If the resident decides they don't want to be compliant with therapy and they don't want to move whatever's broken or affected area, they could get a contracture. Let's say they get a contracture. Well, if it's from that same tibia fracture that we just talked about earlier, the only thing that we're going to do now when they become what is called a sequela or late effects, we would change that D at the end of that code to an S, but we are going to always code the active diagnosis of the contracture first. Do not transition V57.89. That is absolutely correct. We have been using the actual reason. We will be using the actual reason that the patient came into the facility. This is why I've been sending out emails to do not transition V57.89. Again, if we have an example of a patient who came in with a hip fracture and we're going to therapy them. Now, before October 1st of 2015, we will use V57.89 and V54.13 for therapy and the aftercare of that fracture. Now, after October 1st, we will no longer be using those V codes. We will be using those S codes like S72.064D for the fracture, and we will not use that therapy code at all, you all. So don't append it at all. We are using the same mapping and coding concept. Why is the resident here? Okay. What do I do when there are multiple reasons that will keep that resident in the nursing home? What do I do when the resident comes in for therapy but does not have an injury? Part A and Medicaid. Well, you know, when it comes to a resident having multiple reasons that are keeping them in the nursing home, I always say, you all, this comes up to subjection, and this is why it is so important. And I've been saying this since day one. Mapping should be done in morning meeting, where you have a meeting of the minds. What is the most labor-intensive reason that resident is here? Why are we really caring for them? What are we going to put the most emphasis into? What's going to keep them in the nursing home the longest? Map those first. So when a resident comes in and is going to have therapy and they don't have any kind of trauma, same concept that we've always done. What is keeping them in the nursing home? Pneumonia causes debility. We have UTIs even sometimes if they're a chronic sufferer, and it causes weakness and debility and confusion. So the things are, what is going to allow them to have that therapy? What are we coding? What are we really requiring them to have therapy for? Part A, Part A, we have to use those acute care diagnoses. But just like in ICD-9 and ICD-10, you got to watch those pneumonias and those UTIs because they will resolve, and we're going to do the same concept. We resolve them after the billing process. Medicaid, we're going to use the chronic diagnoses. Do not take the trauma codes over to Medicaid. Medicaid don't want to see a trauma code because they want to prove who's at fault. If you submit a trauma code over to Medicaid, they are going to want to know who's at fault, and you're going to have your billing held up. We should be still using V57.89 until September 30th of 2015 as our 67. We're going to use V50. Y'all, I can't say it enough. Do not mess up your billing. Don't mess up your billing. V57.89 until September 30th is fine. Use it, use it, use it. If you have a resident who comes in today, and today is the 24th of September, and we are going to therapy them, use V57.89. Now, after the first comes, we don't use that code anymore. So don't mess up your billing. Don't resolve it until billing goes through for September. That's when you should resolve V57.89 because it's the same concept that we do now. If you take it off right now, it's not going to show up on your billing for September. And as of September, we're still using ICD-9 codes. So please adhere to this. Do not mess your billing up, okay? Don't be apprehensive and go and take it off early because you are going to mess your billing up. Can any V codes be transitioned? Why, yes, they can, you all. You know, you have those therapeutic drug management codes, those status post pacemakers or status pacemaker codes, attention to a tracheostomy, attention to a PEG tube, encounter for therapeutic medicine, insulin dependence. All of those codes, those aren't trauma codes. So therefore, they can still be used, okay? So you can transition some V codes, but we use them the same way we do now. We usually don't map them. So that unless it's something really, really chronic, like a dialysis or something like that. But for the drug management and the status post codes, we normally don't map them up on the list. So it's the same concept that we're using now. Should we use therapy diagnoses as our main diagnosis? No, no, no. Please remember, therapy uses treatment diagnoses, which are in most cases signs and symptoms of the definitive medical diagnosis that we should be using. The coding guidelines specifically warn against using signs and symptom codes that are integral to a disease process. This is why we have to be very careful when we are listing those treatment diagnoses on our residents list, because we can be doing what is called unbundling a code if we map a medical diagnosis and we map a therapy treatment diagnosis that is integral to that medical diagnosis. So we don't want to unbundle that. Like, for instance, if you have a pneumonia, a patient has a pneumonia and a cough. Well, a cough is integral to pneumonia because pneumonia is an infection in the lungs. And of course, the human body is designed to cough to try to get whatever is in that lung out. So therefore, cough is on, everybody's going to experience cough when it comes to pneumonia. So be careful. This can be considered fraud. We don't want to do any fraudulent coding. So be careful, you all. Do not map those therapy diagnoses as your 67s, because for the most case, they are signs and symptoms unless the doctor says this is what they have and we have documentation to prove that. That is something different, because you can have a smoker's cough. Now, if he says smoker's cough, that is not related to pneumonia. But if he has a cough related to pneumonia, it should not be coded, okay? What will we do? Because V57.89 will not be transitioned, but we are using it right now as our admission diagnosis. Y'all, there's more information to come. We want to be on the same page when it comes to this, so I'm not going to touch on this right now, but you will be receiving an email from me sometime early next week, or maybe even on tomorrow. So there is more information to come on that. How many diagnoses can I map? Now, you all know the HIPAA 510 rule says that when we transition over to ICD-10, that everybody has to have some basic type of electronic health records. So they changed that CMS 1500 form where it now has 9 slots instead of 4. And it has the ability to code up to 9 diagnoses. So right now, if you need to, you can actually code out to I, okay? So this is because the new form will allow you to enter in 9 diagnoses. All right, you all, this is it. I will be talking to you all really soon. Okay, have a good day.